I'm very excited to introduce our second speaker. She's an assistant professor at Brigham and Women's, and she's also the associate program director. So we love those program directors. And she received the 2017 Valerie Jackson Education Fellowship Fellow Award. And I am very proud to say that she is the AUR Visiting Professor Awardee, which she has been assigned to the University of Washington to give a visiting lecture. And so I asked her to speak to us, and she's going to be speaking on the science of how we learn, and more importantly, why we don't sometimes. All right, Shanna.
Thank you. So thank you so much for having me. It's really an honor to be with you today from literally across the country in Boston, Massachusetts. So I do think one silver lining of COVID has been sort of forging these wonderful connections. And thank you to the APDR also for including me in this visiting lectureship program. So I hope you got your clinical radiology fix in, because for the next 25 minutes or so, we're not going to be talking about radiology, but we are going to be talking about something that I know we're all extremely familiar with, which is learning. Getting to this point in medicine, we have done a lot of studying and a lot of learning. And I think a lot of us have some good tricks and tips up our sleeve. But I hope to spend the next 25 minutes or so talking about some ineffective learning techniques that are unfortunately quite common. Then we'll talk about some effective learning techniques. And then if we have time at the end, some sort of interesting tidbits that I think are cool about how we learn and why. So I have no disclosures, sort of just reviewed the learning objectives. So, it wouldn't be a talk without starting with the definition, right? So what is learning? And there are, of course, a lot of definitions of learning, but one that I like that is quite simple is the acquisition of knowledge and skills. But I don't think we should stop here, because good learning is not just acquiring the knowledge and skills, but it's being able to retrieve that knowledge and skills from memory when we need to use it. And especially in medicine, that's so important. So what happens when we learn? So day zero, we learn something. Maybe today you just learned something about tendons. I certainly did as an abdominal radiologist. But as time goes on, we forget the information we learned. And the steepness of this curve really depends on how we do that learning. What was the method of learning? And it's quite sad, because you may find that the steepness is so steep that you hear a talk in the beginning of the day at a meeting, and by the end of the day, you can't even remember the topic of the talk, let alone any of the details that you learned. So we'll start by talking about some ineffective learning strategies, which many of these I think we'll probably all be familiar with. So this study surveyed college students at WashU, so not University of Washington, but the one in St. Louis. And, this is a good college. These are smart students. And they asked them, what are your most commonly used study techniques? And they found that the number one listed strategy, and also the number one strategy that people used, was rereading notes or textbooks. So let's talk about repetition as a study strategy. So here are 7 pictures of pennies. We've all seen pennies before, right? We've probably seen a penny more times than we can count. But I wonder, how confident would you be to pick out which one is a real penny and which one are the fake pennies? So I think the point of this here is that repetitive exposure does not necessarily result in learning. It gives us this idea of familiarity, which makes us think that we know something that we don't. So that's this concept of fluency. Fluency is feeling familiar with content, thinking we know it, and it gives us the illusion of competence. And when we learn, we don't want fluency, we want mastery. That's the long-term retention. And again, that important thing, the ability to recall and apply the knowledge when we need to. So this brings me to the concept of metacognition, which is our ability to self-judge, knowing what we know and knowing what we don't know. And I'm sorry to report, but we are very bad at this. So it's hard for us to acknowledge in ourselves the things we know and the things we don't know, because we're often tricked by this fluency. So a couple of other quick sort of inefficient and ineffective learning techniques, cramming, which in the scientific literature is known as masked learning. So I'm sure at some point or another, we've all looked like this before a final exam, sitting in the library till midnight, trying to learn as much as we can. And that cramming, interestingly, does have a very short-term effect. We do get rapid gains when we cram, and sometimes we can actually score better on the immediate tests after cramming. But unfortunately, it leads to faster forgetting. Most of us will forget at least 50% of whatever we crammed within 2 days from that cramming time. So, as I mentioned before, learning is not just, the immediate acquisition of knowledge, but it's that remembering and being able to use it in the future. So cramming might get you the A on the exam, but it's not going to get you the long-term knowledge that we really want and need. So mnemonics are a form of cramming or a form of mass learning. And we love mnemonics in medicine. There are like so many that thousands probably of mnemonics in medicine. And as I was putting together this talk, I was trying to think of some mnemonics that I learned in medical school or in residency. And for whatever reason, the one that came to my mind was mud piles. And it's funny that this came to my mind because I couldn't remember for the life of me what mud piles was even used for, let alone what each of the individual letters stood for. So just like mass learning, mnemonics can lead to sort of an immediate benefit, but overall not good for long-term learning. So this was a study where they gave 2 groups of subjects words to memorize, and they broke them into 2 groups, one group that was allowed to use mnemonics to remember these words, and the other group who just had to do rote repetition. And on the immediate test, the mnemonic group actually outperformed the rote repetition group. But on that delayed test, as I mentioned, there was sort of rapid decline and rapid forgetting, and they significantly underperformed compared to rote repetition. So again, like mass learning, like cramming, mnemonics, not a great technique for learning. All right. My next one, which is probably my favorite ineffective learning technique, is highlighting and underlining. So I borrowed these images from the internet, but I'm pretty sure that this is what my textbooks looked like in medical school. I had a whole, every color of the rainbow highlighter. I had a system, and almost every word would be highlighted. Not an effective learning technique, and I'll show you some data behind that. So, they had a group of students who were broken up into 3 groups. They were given a text to learn. The first group was the control group, and they were asked to just read the text and learn it. The next group was allowed to highlight whatever they wanted as they were studying. And the third group was given a pre-highlighted text, and they were given 1 hour to study. A week later, they were allowed 10 minutes to review their original material. So the active highlighting group was given back whatever material they had highlighted. The passive highlighting group was given back the pre-highlighted text. Then they were given a 54-item multiple choice test. And interestingly, there was no significant difference in the overall test performance. But when they did a sub-analysis, they found some interesting things. The first was that there was better performance overall on the questions that had been highlighted, either in the active group or the passive group. And in those questions, the active highlighting group did better on those questions than the passive highlighting group. But the interesting thing is that the score of the active highlighting group was negatively correlated to how much highlighting they did. So if the whole page was highlighted, it really didn't impact their score in a good way. In fact, it negatively correlated. So I think the moral of the story here is that mindless highlighting, people who just sort of like highlight as they read, that's not really adding to your learning. But if you're being sort of thoughtful about what you're highlighting with intention, that's more likely to be an effective learning technique. So if you're going to highlight, think about what you're highlighting and why. It's more likely to stick with you. Okay, so now I'm going to move on to the meat of the talk, which is effective learning techniques, which is what we all want to know about, of course. So we are going to talk about some general principles and then some important concepts. So the first principle is that effort is good. No one wants to hear this, right? We like things when they're easy for us, but unfortunately, the easiest way is not necessarily the best way. In this line, we also know that making mistakes and learning from them and correcting them will lead to learning. So sometimes the tough stuff is actually good for us. The next concept is that learning styles, I'm an auditory learner, I'm a visual learner, that this is really a farce. This is related to the first principle, because what feels easy to us or what feels comfortable to us may not actually lead to long-term learning. So it's actually better for us to really draw on all of our aptitudes and resourcefulness rather than limiting our learning to things that feel comfortable to us. And then finally, I already touched upon this earlier, keeping in mind that we have poor self-judgment, this sort of concept of metacognition. All right, so concepts and effective learning. There are three concepts, and they're actually all related and they build on each other. So we'll start with active retrieval. So active retrieval, another term for this is testing. And of course, in medicine, we're very familiar with testing. We've probably taken thousands of tests in our career, but those tests have always been graded and have a lot of value to them, right? They are make or break in many ways. When we talk about active retrieval, we need to reframe the way we think about testing. So instead of a tool to measure learning, to grade us, it's really a tool to facilitate learning. It tells us what we know and what we don't know, which helps us with our metacognition, which we know we're not good at. It helps consolidate memory, reconsolidate memory. It decreases forgetting, and it helps us improve future recall, which is the point of learning anything in the first place. So some research behind this, there was an 8th grade science class in Illinois, and they hired a research assistant who created these no stakes quizzes. So they were ungraded quizzes on a third of the material that was taught that year. The students had a quiz before the lesson, after the lesson, and before the exam. And interestingly, the students scored significantly better on the quizzed material than the unquizzed material. And when they were given a follow-up exam 8 months later, this effect persisted. From the student perspective, they actually really liked the no stakes quizzes. It reduced the anxiety of the graded exams, and it felt to them like it increased their learning. Benefits to the teachers are that it improves attention, it increases attentiveness because the students know that they're going to be getting a quiz. And even though there's no grade, no one wants to get a bad grade on a quiz. So it helps with attentiveness. And then it also helps us adapt instruction to fill gaps, especially if you're doing the quizzing in real time. So, in the modern day and age, we can use Poll Everywhere during our talks to sort of assess learning as we go. And as we know, the Poll Everywhere usually doesn't count for anything. I let my residents go in sort of anonymously or make up fake names. So it's truly anonymous. So the next question is, well, does the type of testing matter? And the answer is yes. So generation type testing, which are things like essays, fill in the blank, short answer, or flashcards, these are more effective than recognition type testing, like, multiple choice or true false questions. Because again, the recognition type testing helps us, we sort of rely on that fluency idea, the idea of familiarity, and we may see the answer within 4 options, but it doesn't mean that we're able to recall that answer from scratch. So remember that effort is good, although we don't like to put in the effort sometimes. Okay, so moving on to the next concept, which is spaced practice. So the idea here is that I showed you this curve, this very sad curve earlier. We learn something and then we forget it. And that active retrieval is a way to remember it. And so each time we actively retrieve the information, which is sort of up here, we remember, we reconsolidate that information. So the space between those active retrievals, that's the spaced practice. So sort of understanding how frequently should we be reviewing this information to help us reconsolidate it and to decrease this forgetting curve and to basically flatten out the forgetting curve. So spaced practice helps us consolidate. It also helps us connect prior knowledge. So of course, we always want to be building new knowledge. So it helps us connect the stuff we learned previously to new things. It also helps us triage what we don't remember. So if we're testing ourselves, we can sort of pick out the areas that we are less comfortable with and spend more time sort of reviewing those areas. And remember, again, the spaced practice, it might feel hard, right? We've learned something, we've taken some time, and now we're reviewing it again. We probably have forgotten some of it, but actually that effort is good. We want our brains to have to work a little bit hard to retrieve that information. So a little bit of forgetting is good, but not so much forgetting that you're actually starting from scratch. So an example from the medical literature looked at a small study of 38 surgical residents who were learning microvascular anastomosis, and they broke them up into two groups. The first group had a sort of simulation session that was performed in one single day. They were the massed practice group. And then the other group had a space practice where they had 4 training sessions across 4 weeks. But the total amount of teaching time was equal between the two groups. So they assessed the groups before the training session, and they found that their skills were equivalent, that there were no differences between the two groups. And then they test the groups immediately post-training sessions, and they found that they both essentially equally improved. There were no differences between the two groups. They then did a delayed post-test, and they found that the mass practice group, although it had improved from their personal baseline, were not as skilled as the spaced practice group. So the spaced practice group was doing better. Then they asked the students to transfer these skills to a live sort of patient. They used rats, not real people. And they found that the mass practice group then reverted to their baseline skills, whereas the space practice groups had actually improved from their baseline. So it sort of suggests that the space practice may even lead to better versatility, sort of improved ability to transfer knowledge to future events and things like that. Okay, so then the last concept here is interleaving. So even if we're subspecialty radiologists, of course, there's a lot of things to know in our subspecialty. It's not like we're learning just one topic. So how do we weave in these topics? Do we focus on one at a time, or do we mix and match? And the idea of interleave practice is that it is actually better to mix topics rather than to do sort of clustering or blocked studying. This leads to better mastery and greater versatility. So an example from the literature was that they had a group of college students who were taught to measure these very sort of odd shaped geometric solids. So they had a wedge, a spheroid, and so on. And they broke them into two groups. One group who did sort of blocked or massed learning. So they only sort of learned about one solid or one shape at a time. And then the other group who was learning about all of the shapes all at the same time. And similar to mass learning that we talked about before, during the practice, or sort of like the immediate post-test, the blockers actually outperformed the mixers. So again, that concept that massed learning or blocked learning does lead to rapid gains is shown here again. But on the delayed post-test, the mixers significantly outperformed the blockers, and the blockers didn't do very well at all. And so this sort of explains why mixed or interleaving topics, it leads to ultimately better retention, better discrimination, and better versatility. The interesting thing is that from the student perspective, they did not like the mixed learning. They liked mass practice. They felt like that was better. And I think, it's unclear exactly why, but my theory on this is that mixed practice is much harder. You don't feel like you're getting good at something before you move on to the next topic. When you're only learning about one thing at a time, you can sort of develop confidence before you move on. But the mixed learning or the interleaving of topics is what makes us sort of more masterful in our learning. And so again, effort doesn't feel good, but it is good for our learning. All right. So in the last 5 minutes, I'm going to talk about a few more concepts in learning that I think are particularly interesting. So the first one is cognitive overload. So cognitive overload is stress on our brain when we're trying to learn new information. And our working memory is the big one that's at play here. This is the part of our memory that actively processes and manipulates information in real time. It helps us integrate new information that's coming in with past knowledge that's already in our brain. But as we know, the working memory has very limited capacity. And so when we overwork that that working memory, we sometimes feel a little bit like our brain's going to explode. So the working memory is made up of 3 parts, and we can sort of break down these 3 parts to decrease the stress on our working memory. So the first is the intrinsic component, which is the inherent difficulty of a task. And the way that we can reduce the stress on our working memory of that is just breaking things up into smaller subtasks. So you're just thinking of one thing at a time. The next component is the extraneous component. And this is all the non-essential information that we are taking in, but is really not relevant to what we're doing, but it's requiring our brains to do some processing. It's essentially taking up space. So ways to get rid of that is to eliminate as many unnecessary distractions as we can. And then the germane component is how our brain makes sense of the information that we're taking in. So sort of the processing and the learning. And a way we can sort of reduce the stress on our working memory is by using frameworks and recognizing different relationships. So I think working memory is especially relevant for procedural radiology. I do some abdominal intervention, and I am frequently working with residents who have never done these procedures before. And I see them walk into the room and they're overwhelmed. There's the vital machine going off, the patient is talking to us because they're sedated but not quite sleeping. There's multiple steps of a procedure. Occasionally procedures are complicated, and I see them getting overwhelmed. So I sort of think about this framework and I try to break the procedure into small subtasks. We talk about these before we go into the room, sort of stepwise, what we're going to do next, then we regroup, what we're going to do next, then we regroup, and so on. I also make an effort to eliminate unnecessary distractions. So for our sedated patients, for example, I tell the nurses, let us know if the vitals change. Otherwise, sort of direct the screen away from us, because again, it's sort of a distraction, and the nurse is there to help us. And then finally, using frameworks, if we're doing a drain, for example, a lot of residents are already familiar with the Seldinger technique. So instead of knowing, the 4 steps one by one, just sort of using the term Seldinger helps them sort of use that framework to break down complex topics. Another idea in this cognitive load theory is the idea of multitasking. And I know a lot of us think that we're very good multitaskers, but really we're just rapidly switching between tasks. And it's basically just dividing our working memory into smaller and smaller components. One kind of cute example from the literature about this is that subjects were asked to complete a memory test. They were either in groups where they were sitting to do this, standing, walking along an oval track while completing this memory task, or this very funny looking aperiodic track. And although there were no significant differences in the sitting and standing group, the walking oval track did slightly worse on the memory test, and the aperiodic track did significantly worse. So this makes me think I am not a radiologist who can stand and work at the same time. I have trouble concentrating, so I probably would not be in this group. But, again, walking and trying to do a task just, again, breaks down that working memory into smaller and smaller pieces. We also in radiology have this sort of idea of dual channel processing and overload. And this is especially relevant to our specialty because all of our teaching is very visual. We always have important images. And so a lot of our PowerPoints look like this. There's a picture of a finding on radiology, and then there's some text. But we're causing now our sort of visual sort of processing to both look at the image, but our visual processing is also reading the text. So it's split attention. What we really want is for the audience to be focusing on the image and listening to us. So we're using 2 different senses and not one is overloaded. So a better way to present this slide would be to only have the image, and then for me to be presenting to you verbally what the findings are. So that way your visual processors are able to look at the image, and your auditory is able to hear what I'm saying, and none of them has split attention. Okay. We are running out of time. I do want to leave some time for questions. So I'm going to skip very quickly just to my favorite concept of learning, which is the curiosity effect. So what is amazing to me is that actually your motivational state during learning can have an impact on your long-term learning. So this study basically put people in the study, and they asked them trivia questions. And before they gave them the answer to the trivia question, they asked them, how curious are you to know the answer? And there was a 15-second delay. They flashed the image of a random face, and then they told them the answer. A day later, they brought those subjects back and they asked them the same trivia questions. And they found that people were more likely to remember the answers to the trivia questions that they had previously been curious about. And then even more interesting was that they then showed them sort of like a list of faces. And the faces that they had been shown during that 15 seconds where they were curious about the answer to the trivia question, they were more likely to remember the next day. So you can actually get people to learn something that is even unrelated to what you're teaching just by sort of getting them curious, getting them into a curious state. So, like ways we can do this in radiology is starting talks with a short quiz or an unknown case, sort of getting people interested and wanting to hear what the answer is. And then hopefully they remain curious for the rest of the talk so that more of what you're teaching them will stick. So we've talked about ineffective learning techniques. Unfortunately, many of them are commonly used in medicine, but we've also talked about some effective learning techniques. I hope that you'll be able to incorporate some of these into your practice, and then some other sort of interesting ways about how we learn or how we don't learn, and that. So in summary, remember, effort is good. Even though it feels hard, it's actually better for your learning. Remember that we have poor self-judgment. So a way to bypass this is by testing yourself, essentially. Use spaced and interleaved active retrieval for better long-term learning. And when all else fails, just elicit some curiosity.